Hey, everybody, it's Dr. Eric Balcabbage. We're back for another edition of the Thyroid Answers podcast. And we have another guest today. We have Dr. Jody Stanislaw. She is a naturopathic physician, but today she is primarily a person who specializes in helping people with blood sugar challenges, especially type 1 diabetes. So, Jody, welcome to the Thyroid Answers podcast.
Awesome. Thanks so much, Eric. Happy to be here.
So we met at a conference not too long ago out in Arizona, and we struck up a conversation. I thought, man, this would be a good person to bring on the podcast because so many people have blood sugar regulation issues, and there's a huge tie to thyroid physiology. So we'll get into that in a little bit. But you started telling me your story, and so I was like, hey, we need to get you on the podcast to have a discussion. So can you give the listeners a little bit of background about you and why you're so passionate about blood sugar physiology and especially different types of diabetes?
Absolutely. So I was diagnosed with type 1 in 1980. I was 7. And so I've been managing my blood sugar every single day for, 43 years now. And so I have definitely a different perspective on blood sugar than most people because my whole life I've been like, how much sugar's in that? 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 And then before my continuous glucose monitor, which I got probably 5 or 10 years ago now, for 30 plus years, I'd poke my finger 15, 20 times a day. What's my blood sugar now? What's my blood sugar now? And so I've spent my whole life thinking about my own blood sugar. And then I did a TED talk recently called Sugar is Not a Treat. And I'm happy to say it, people love it. It's got like 4.5 million views now. And I really am passionate on helping other people realize how damaging sugar is to them, whether or not they have diabetes or not, because it's pretty heartbreaking to me every time I go into a grocery store and realize 80% of the food is stuff I wouldn't touch because it's all processed with sugar. And yet that is what people are eating all day long. So I really am passionate about educating people on the damages of that. And the sad thing is it's so pervasive, it feels normal.
Yeah.
Right. And that's what I'm trying to shake people out of.
Yeah. And we're going to get into it a little bit later because there's a whole group of people that are doing their best to regulate the amount of carbohydrates and sugar they're putting into their body, and yet they still have glucose or insulin resistance, prediabetes. So we'll talk about that a little bit more. But let's first talk about how massive of a problem blood sugar regulation is, especially in the United States. I mean, there's numbers like 11% maybe of the adult population has diabetes, but the amount of people that maybe have prediabetes, it's estimated somewhere around maybe 40% of the US population. Do you think those numbers are accurate, or you think that maybe it's an even bigger issue than that?
I think it's even bigger because, I mean, you can just go to Costco or go to any grocery store and you can see what people are buying. Mm-hmm. The masses are putting processed sugar in their cart all day long. And that's pretty clear on the street data. The CDC says that if our diet does not change at the trajectory that it's going on right now, 1 in 3 will have type 2 diabetes by 2050. Mm-hmm. So 1 in 3. So that's 33%. So our numbers of obesity are skyrocketed. Our health statistics are not good, right? The number one reason why people die from high blood sugar is heart disease. So when we look at the stats of how many people die of heart disease in the country, my question is, how many of those people is it blood sugar related? I mean, obviously there's many reasons why people die of heart attacks, but sugar is a big one.
Yeah. I think if we think that the numbers look like it's about 50%, right now that have diagnosed prediabetes or diabetes, there's a whole nother 20-30% that are on their way. They already have glucose resistance, right? And they're now increasing levels of insulin to do something with that glucose level that's stacking up in the bloodstream. So I think it is a huge issue. So, but I think it's really important that we talk about glucose and insulin, because I think both of those things get a bad rap, but they're not bad things, right? Can you talk about the significance and the importance of blood sugar, glucose?
Sure.
Why is it important? What do we do with it? And where does it come from? So let's start with why is it important?
Well, it's the main fuel for the body and it's the main fuel for the brain. If you don't have a certain amount of glucose in your bloodstream, you die.
Mhm.
Like if I give too much insulin one day because I miscalculated my dose, insulin is the pickup truck for glucose, right? Glucose comes into the bloodstream after we eat, and then it triggers the body to make insulin, assuming you can make insulin, which I cannot. And then insulin picks up the glucose out of the blood and it feeds it to the cells, right? So you have to have it to be alive. You absolutely have to have glucose to be alive. And can we hold on just 1 second?
Yeah, you got it.
Yeah. So yeah, just go real quick. All right. So glucose is necessary to be alive. Your muscles need it. Your brain needs it. It's fuel. We are a machine and we need fuel. So we can't vilify all glucose. Glucose is necessary for the body, right? And insulin is necessary to be the shuttle. We need insulin. We need insulin to shuttle the glucose from the bloodstream into the cells. So I mean, I can go on for 10 minutes on this.
Well, I think you hit the good points, right? So it's important cells use it to make cellular energy, right?
Energy.
You need glucose. We get that from our diet, but the body also makes it. And Dr. Jody was talking about how important it is. It's so important that we have 4 hormones that their whole job is to increase the amount of glucose in the bloodstream, right? That's how important it is. So we've got 4 hormones that actually cause it to go up. We only have one hormone to bring it down, right? That's how important it is. Getting it down is important, but maintaining glucose is critically important. But we get it from, if we don't eat, our body will make it, right? It has a way of making it.
Yes.
And so there are people who have high blood sugar, not always because of they consume excessive amounts of glucose, because they've got these other hormones are being stimulated or activated to raise glucose. But we definitely have an issue when it comes to consumption, right? And you already talked about that. And the problem's huge, right? There's excess glucose in everything. We had the goofy thing called the food pyramid that started out like you could eat as much carb, 11 to 13, right? And so we did that, and there's plenty of discussion about how that model got developed and the problems with that model, and yes, the money behind that model and why it was problematic. But I agree, it is a huge issue, but we need glucose. So now we got to talk about how does this work once we get glucose? Let's talk about insulin a little bit, right? You talked about insulin, its role is to take glucose and put it into the cells, right?
Yeah.
So how is for some people, their assumption is that the only way, how does glucose get into the cell? Is it only by insulin, or can it get in there via other mechanisms?
Yeah. Well, so let me just back up a little bit. So when I was diagnosed, I was 7 years old. Mm-hmm. And I was wetting my bed every night. I was crying because I was so thirsty. I had almost no tear fluid, no saliva. I was massively dehydrated, losing weight. So I always like to understand the mechanism and explain the mechanism to people. So what was happening is I'm eating whatever it is. Doesn't matter if it's a chocolate chip cookie or a banana or an apple or a piece of toast, healthy carbs, unhealthy carbs.
Go ahead. I'm sorry.
No problem. So when I was 7, I'm eating this food, and I'm getting massively dehydrated. I'm losing weight, and I'm wetting my bed every night, crying because I'm so thirsty. So let's think about why all those symptoms are happening. The glucose I'm eating is going into my bloodstream. And I don't care if, like I said, if it's bad sugar or good sugar, if it's an apple or if it's M&Ms, whatever, the sugar goes into the bloodstream. If there's no insulin in the body, which is what type 1 diabetes is, autoimmune destruction of the insulin producing cells, then my glucose is basically stuck in my bloodstream. It cannot feed the cells. So I am now losing weight and feel starving because although the food is going in my mouth, the glucose is stuck in my blood. And what the kidneys are doing is they're massively dehydrating my body because the kidneys have to flush out all the glucose. So I'm like peeing out glucose. All my calories are getting peed out. So that's why I'm crying, because I'm so dehydrated. My eye fluid is gone. My saliva is gone. I'm losing weight because the calories I'm eating, are peeing out, right? The second I start taking insulin shots, all that reverses, right? Because now my glucose that I'm eating can actually feed my cells. So it is, now you asked, do you only need insulin to get the glucose in? No, you also can exercise. So exercise obviously burns up glucose. There's things called GLUT4 receptors. So GLUT4 receptors come up on the muscle cells. They're the ones that insulin binds to, and then they open up the cell and allow glucose to come in. Well, when you exercise, your GLUT4 receptor concentration up is substantially higher. And so a lot more glucose, and sometimes muscles can take it in even without the presence of insulin, right? So GLUT4 receptors are going to pull glucose in. So exercise is one of the best ways to burn glucose. But even in that state, even if I was climbing Mount Everest, you still need insulin to be alive. You cannot exercise enough to keep your blood sugar managed if you do not make insulin. Insulin, if I stopped taking insulin, I would be dead in the next few months. You cannot be alive without insulin.
Yeah. So let me jump on that a little bit too. So one of the things you said was the dehydration. And for the listeners, the other thing that's going to create dehydration, we see this in people who just don't make energy well. When we talk about the cell stress, cell danger physiology, is when you bring glucose into a cell and bring it in and convert that into cellular energy, one of the byproducts of making cellular energy is cellular water. So when you don't bring glucose in and make a lot of cellular energy, not only are you tired, are you fatigued, cranky, irritable, all those other fun things, but the glucose stacks up. You talk about having to pull fluid and pee that stuff out, but you're also not making the cellular energy. So your actual cells are dehydrated from that perspective as well. The other thing I want to kind of jump in there and talk about is how it gets in there, right? So in a fed state, most often we see the rise in insulin, right? And the insulin activates those there's glucose transporters, and there's a number of them, okay? And so the GLUT4, which is what Dr. Jody was talking about, is the one that's insulin dependent. That's the one that insulin binds to, that brings glucose into the cell. And that's, if you think about the glucose receptors or these glucose transporters, they're like doors, right? They open it up, right? And so if the insulin receptor opens a really big sliding door, right? You can really get a lot of stuff in there. But there are other glucose transporters that don't require insulin, and they can push glucose in and out of the cell. The one thing that's really important, because this is the Thyroid Answers podcast, we're going to talk about it, is all of those glucose transporters are dependent on appropriate levels of T3 inside the cell. So anytime somebody has hyperthyroidism or hypothyroidism, there's a higher prevalence of having blood glucose dysregulation. And we won't necessarily get into all that complexity, but if you've got hypothyroidism, whether it's glandular or tissue, the tissues that have a low T3 state, they're not going to transport glucose very well, right? In an insulin state, or in a fed state, or in a fasted state, that's one of the reasons why sometimes we'll see somebody who hasn't eaten a lot. How could my fasting insulin be so high? One of the reasons is because you can't get glucose in there in a very efficient way. So what does your body do? It keeps the insulin levels jacked up to try and force that glucose into the tissues. So I want to just jump in and put that in there so that people who are going, well, I don't eat a lot of glucose and I'm still insulin resistant. We'll dig deeper. But one of the ways that this ties to thyroid physiology is all those glucose transporters are dependent on the level of T3 inside the cell. So let's talk about, why do you think, and I know one of the reasons you're going to think, but why do you think most people become, and I like to say glucose resistant more as, not just insulin resistant, because insulin's trying to do its job, but there a lot of times I look at it from a glucose resistant standpoint. Why do you think so many people, is it just overconsumption for some people maybe, but what's your big picture thinking?
Two things I think of. Any area in the body that's overused will wear out, right? If you play too much tennis, you get tennis elbow, right? Whatever you overuse, it wears out, right? We look at the screens all day. Now our eyes are, going bad sooner. So the GLUT receptors, there's resistance at the cellular uptake because the cells basically are sick and tired of taking in so much glucose. And so the receptors, there's actually a pathology. That's why I differentiate between insulin resist or having pathological insulin resistance or just normal insulin resistance. Like if you sit on your butt all day, you won't be as insulin sensitive, right? You'll be more insulin resistant, but that's not pathological. Type 2s or pre-diabetics, their ability to upregulate the receptors is weak. Those receptors are worn out. And so sometimes if I'm on, let's say 30 units of insulin a day, a type 2 might be on 100 units of insulin a day because they have to hypersaturate the body to really get the insulin to be able to open up the receptors because they're so low concentration. Do you agree?
Do you think, I don't know if I necessarily totally agree, but like we all have opinions and bias, right? So I think, in my opinion, a lot of times is we blame it on the glucose and we consume so much glucose that maybe things wear out or that we fatigue the system. I think a lot of people, there's another thing here, and I talk.
Point, but I'm curious what you're going to say.
Yeah, so I talk a lot from what I call the cell danger response, right? So we live in a world where we've got excessive levels of stress, excessive carbohydrates, excessive sugar is one, but we also have chronic dysbiosis, we've got sleep disruption, breathing problems, we've got emotional stress, and cells. I look at self as toxins, organisms, right? And so I look at cells like people, right? We're either in one of two operating modes. We're either in low stress, homeostatic, manufacturing function, right? Where I need to bring glucose in and convert that into energy so I can make proteins and peptides and hormones and all kinds of good stuff that makes me feel well. Or I'm in an excessive stress state, we call allostasis. And in that state, whether it's triggered by emotional stress, disrupted sleep, organisms, toxins, I don't want to bring more nutrition into the cell, right? I'm trying to stiffen the cell membrane. I'm trying to, if there's a bacteria or virus in here, I want that thing to get trapped in here. I want to find it. I want to kill it, right? And so what I see in my practice a lot is the people who are struggling, they're already on a paleo diet or a low carb diet, and they still have blood sugar regulation issues. And that's the case where I think many times the cells are resisting the glucose transport, not because there's excessive amounts necessarily.
They're in survival mode.
They're in survival mode, right?
Yeah, so, absolutely.
Is that what I might have stole your number 2, but I think the one thing is excessive intake. I think the other thing is we see a lot of people in danger physiology on a chronic basis. So I'll let you jump on that a little bit more.
Your second one basically is the umbrella, really, it fits in with what I just said, which mine was just too narrow, but you had a much more broader picture of like why the cell shuts down, really. Mm-hmm. But there also is the other thing is the more toxic you have, like toxins. Absolutely. We are inundated with chemicals these days. Newborn babies are found to have 200 different chemicals in their, in their cord blood. So, and a lot of toxins are fat soluble. And what does every cell membrane made of? Fat, right? So where do the toxins get stored? They get stored in cell membranes. And when you have a bunch of toxins in the cell membranes, it does not allow all those cell communication, everything on the cell. Everything that the cell needs to do, it has to communicate with the outside world through its cell surface. Yep. And so there's a lot of people with cell membranes that are poorly functioning due to the inundation of the toxins, not allowing all of their receptors to work properly.
Yeah. So and I think that ties right into what I was saying. So I think we're on the same page there, which is, hey, it could be excessive consumption, right? There can be where you just you're consuming more than the body can manage, right? That's problem one.
Definitely a fact in our country.
Absolutely. And then the other is, and especially for the person who's listening to this and going, but I don't eat a lot of carbohydrates and I'm pre-diabetic, you're probably in that second category where there's something created an excessive cell stress response where your body's like, I'm not bringing more glucose in. I bring more glucose in, I feed an organism, I feed a threat, or I'm threatened, I'm stiffening the cell membrane, or the cell membranes aren't working to begin with. And so now we have this other issue. So where does the glucose go? Right? So when somebody has this insulin resistance or glucose resistance, can you talk about where does all the extra glucose go?
Well, it often stays in the bloodstream, and then that's what's going to raise your hemoglobin A1C and too much blood, and then of course your kidneys can clean it out. And high blood glucose levels lead to heart disease, kidney failure, strokes, gangrene, blindness, right? Toe amputations. Too much glucose stuck in the bloodstream is I always say diabetes doesn't kill you, but high blood sugars do, right? If the sugar can't get out of the bloodstream, it's going to do a ton of damage.
So for the listeners, can you talk about how does it create damage?
Well, I always try to keep things real kind of layman simple.
Yeah.
But I make the analogy of like shards of glass circulating through the bloodstream, right? It degrades the walls, the arterial walls. Retinol. Now, to get more cellular granular, you're going to have to. I can't remember all the.
Oh no, that's okay.
Sorbitol buildup, the cell, and then it makes more vitamins, that whole thing.
Yeah, I don't think we need to get that technical, but I think the key is the way I try and explain it to patients is sugar is like sticky, right? And so when you have this sugar building up in your bloodstream, it's like everything is sticky to it. We've had syrup or sugary sticky. It's like sticky on everything. It sticks to your red blood cells. They don't work good. It sticks to other proteins and hormones, and none of the stuff works good. It's like everything gets gunked up by this sticky, sugary stuff. So when you think about why would it be a big deal, think about having a bunch of sugary, syrupy stuff stuck to everything, and you're like, oh, but that's how your body is trying to wade and work through that stuff. Nothing works as good when it's all junked up, right?
Right, and that's exactly. I love explaining the mechanism of the A1C test. So people, they'll say, "Oh, I tested my fasting, it was good," and I'll try to explain that's 1 second in time, right? The hemoglobin A1C test is looking at your average blood sugar over 3 months. Right. So how people are like, what do you mean? I could take one blood sample and get what my blood sugar is, but for 3 months? I'm like, yeah, because it's looking at how much glucose has stuck to the hemoglobin protein in your red blood cells, and red blood cells live about 3 months. So that is the hallmark of, a key for diagnosing prediabetes or even monitoring your blood sugar level from year to year, right? Is your A1C 5 and the next year it's 5.3 and the next year it's 5.7, the next year it's 6.2. But yeah, and then actually just yesterday I was talking to my group and we were doing shoulder stretches. And I said, you guys, how often are you stretching your shoulders? Because people with high blood sugar have a higher risk of frozen shoulder because connective tissues are one of the key things that glucose likes to stick to as well. So diabetics with poorly controlled blood glucose definitely have a higher risk of frozen shoulder, of getting tight. I do yoga almost every day. So that's my, and I keep my blood sugar levels, pretty good. But yes, it sticks everywhere. Red blood cells, connective tissue.
Yeah, almost everything gets gunked up by it. We'll break down some of the tests here in a little bit. But do you see, I already kind of laid in there a little bit about thyroid physiology and the impact, but you're dealing with a lot of people with type 1 diabetes. Do you see a connection between the people you see who have blood sugar issues also having thyroid issues typically?
Yeah. Oh yeah, very common. And not only just thyroid issues, but Hashimoto's, right? They have the antibodies, because when you have type 1 diabetes, your risk of celiac goes up 20%, your risk of, or I think 20% of type 1s have celiac, 20% of type 1s have Hashimoto's. The antibodies also go up. So you have a double whammy. You have antibodies attacking the thyroid, and you have the blood sugar dysregulation affecting T3.
Yeah, there's for the listeners, if you get diagnosed with type 1 diabetes, oftentimes they'll run those other two.
Yeah.
They'll be checking for celiac, they'll be checking for Hashimoto's, because it's like a little triad that goes together, right? And so the link there is they're all autoimmune driven disorders, right? So if they're immune driven disorders, and these are like the three most common immune disorders, there's likelihood of, if you get one, you're likely to get another. And there's some other common antibodies that are seen in both type 1 diabetes, that are seen oftentimes in other autoimmune disorders, like GAD65 is a common one that you can kind of see in a number of disorders. So, all right, so let's get down into the different things that are going on here so people understand the difference between insulin resistance, prediabetes, and then we'll talk about the different types of diabetes. So what's the difference between insulin resistance and prediabetes for somebody? If they hear those terms, how do you define those?
They kind of go hand in hand, right? So prediabetes, generally, if you're pre-diabetic, you're probably insulin resistant. You want me to go deeper on that? Is that what you're asking?
Yeah, I think somebody says, well, I'm fine because I just have pre-diabetes, but my insulin's not that high yet. Or they're just told they have insulin resistance, and they're like, okay, but what does that mean? So is there a number? Let's talk about numbers then. So when you look at somebody who's got, like when I would think about differentiating it, if I start seeing a person with an insulin that's climbing over 8, I'm now concerned this is a person who's already into glucose and insulin resistance, because it's taking them more insulin to get glucose into the cells. Does that make sense?
Yeah, sure.
I'd look at defining prediabetes as somebody who's kind of getting over that 5,
7,
5, 6, 5, 7 mark, right? And so you could be already into insulin resistance or glucose resistance, still have a hemoglobin A1C 5.4, 5.5. And to me, that's why it's important to not just look at a fasting glucose, not just look at a hemoglobin A1C, but look at your fasting insulin level or C-peptide value. We want to know how much insulin it's taking to maintain that. Do you look at those same things, and do you kind of define it the same way?
Well, I don't, because I 100% work with type 1 diabetics who are already diagnosed.
Okay.
I don't work with type 2s. I don't work with prediabetes.
Okay.
I'm 100% working with type 1s. But of course, if I had a wider practice, absolutely. Because it's a trajectory, right? The first red flag goes up, second red flag goes up. And unfortunately, in today's medical world, sometimes they don't do anything until all the red flags are up. And so you and I are talking about, really being thorough, not just getting fasting, not just getting hemoglobin A1C, but those insulin levels. And you're absolutely right, because it doesn't just, even type 1 diabetes now, it doesn't just happen overnight. They can measure the autoantibodies months, years in advance now. So type 1 diabetes, type 2 diabetes, type 1.5 diabetes, they're all on a trajectory. And how soon you diagnose it and how soon you take action, the better.
All right, so let's break it down to different types of diabetes. Okay. So let's talk about what's type 1 diabetes.
Type 1 has to have an autoimmune component. That's really the main differentiation. And there's about 4 different autoantibodies that you can test. GAD65 is the most common one, and there's 3 others. But if you have, so an adult onset type 1 is called type 1.5. And it also has an autoimmune component, but the autoimmune attack is just slower. So classic type 1 is a swift autoimmune attack on the beta cells. Now I can say swift, but my autoimmune attack still could have happened months and months and months prior to my actual symptomatic picture, right? They say I have about.
But do you think we see the type 1, do we see more in the younger population, and the 1.5 more in the older population, or do you think that's been?
Yeah, 1.5 is also called LADA, which is latent autoimmune diabetes of adulthood. And so I've never heard of a child having a 6-year onset before they needed insulin, which is common in the adult onset. Type 1, classic, you're under 18 and you need insulin the day you're diagnosed.
Yeah.
Type 1.5, you're over the age of 30. And maybe if you immediately do some gut healing, low carb diet, increase your exercise, you can manage a really healthy, clean life without needing insulin yet. And I have a whole process of how I help them kind of prolong that quote honeymoon period. But an adult onset type 1.5, they have an autoimmune attack, but it's just not as swift as the juvenile.
Yeah, and I've got a nephew who's got type 1 diabetes, and you kind of had, when he got diagnosed, it was acute, right? Out on the football field, something's wrong. Oh my gosh, got to take him to the hospital. He's got type 1 diabetes. But you probably, if we really look close, there were signs and symptoms along the way, but
100.
you wouldn't have guessed, because here's a kid who's a rambunctious, healthy kind of jockey kid, right? You wouldn't have thought that there's a problem, right? You didn't have like a typical, maybe what we'd see in a type 2 diabetic, like overweight, obese. It's not the same look, right? So I think go ahead.
For two different names. They should have complete two different names.
Yeah.
Type 1 diabetes should be called something completely different. I mean, yes, we both have blood sugar dysregulation problems, but the onset of type 1 is autoimmune, right? And I can talk a whole bunch of theories as to why that happens. Type 2 is not autoimmune, right? And they're just a completely different picture of who they are. So type 1s are not overweight classically. I mean, they can be, just like the general population, but that has nothing to do with initiating the autoimmune disease.
So let's talk about there's lots of theories, lots of philosophy or thoughts on what causes it. What do you think what do you see as the leading causes of type 1 diabetes?
Well, there isn't a leading cause. It's kind of a cocktail. There's often a genetic predisposition, but it doesn't have to be. There's often a viral infection. Over 30% of type 1s have had a viral infection in the previous months. And then you can throw in a lot of the other theories, right? Low vitamin D, gut inflammation. They even were looking at if you were breastfed and at what age you introduced cow's milk. There's theories about that. Stresses to the immune system, basically. All of those are stresses to the immune system, right? A viral infection is a stress to the immune system. Low vitamin D weakens the immune system. Not being breastfed weakens the immune system. Introducing cow's milk brings in a foreign protein at an infant age. Foreign proteins, it confuses the immune system. So emotional stress has been considered a big trigger, of course. So anything that weakens the microbiome weakens the immune system. So anything that confuses or weakens the immune system
can trigger. Yeah. And what's interesting, if we think about that, right? If we talk about what happens in type 1.5, we might say a lot of the same things play a role. And then if we say, okay, but what about type 2? It could still be a lot of the same things, right? So it could foundationally, there's a lot of the same things that can trigger this immune response, and that how that immune response affects an individual could be different. And that there may be that genetic predisposition, but it's these epigenetic factors that turn those genetic expressions on or off, right? That now we have this issue and this problem. And I know, I really think for my nephew, emotional stress from what was going on with their family was a huge factor in what triggered the response and triggered this kind of onset. So, all right, let's talk 1.5. What's the difference between what's 1.5? I think we kind of alluded to some of the causes, but what are the thoughts as to why this develops this latent onset in adults, right?
It's actually been happening for quite a long time, because I have so many patients who tell me they're in their 60s and 70s, and they said they were diagnosed in their 30s. So this is not, a new thing. But it's all the same that I just explained. It's like genetic predisposition, maybe a viral infection, anything that weakens the immune system. There's a lot more toxins and nutrient deficiencies today. There's a lot more stresses today. And so perhaps the immune system is stronger because they're 30, 40, 50. They're not 6, 7, 8. But there's no difference in the onset of a juvenile and adult. Just the adult, for whatever reason, comes on slower. But the problem is any adult that has elevated glucose is often immediately given metformin, and then they're just assumed to be type 2. So that is a huge problem, because those people risk going into DKA And they're, I've had so many patients say they were given metformin, they were still 250 for a year. Then, then they had to wait 6 months to see the doctor. So then they were given the second, glyburide or whatever their second med was, or the third med or the fourth med. And finally they found that tested their autoantibodies, their GAD was through the roof. They got on insulin. And for the first time in 5 years, they were below 150. That happens often.
Yeah. So that was going to be my next question, since you already jumped in it. We'll kind of talk about it, but that's the problem when somebody is when they're into adulthood, right? I think a lot of times, because we don't run more comprehensive panels, we just run maybe a fasting glucose. I see so many people that don't even get fasting glucose levels done. They go look at their blood work. I'm like, did you eat before this? Oh yeah. My doctor, he just said take whenever. So I took it whenever. I'm like, yeah. So this fasting glucose means nothing, because it's not a fasting glucose. You don't have a hemoglobin A1C here. Or if they do run a hemoglobin A1C and they have a high glucose, it's assumed they're pre-diabetic type 2, right? And so this is the standard treatment for type 2. But if you don't look at insulin, right, you don't know what's going on with an insulin or a C-peptide, you can't differentiate the difference. That it looks the same on a blood panel, right? Hemoglobin A1C is up, fasting glucose is up, or glucose is up, and so it looks the same. So they get treated wrong. Yeah, so it gets treated wrong. We just assume. Yeah. Right. And you know what they say when you assume, right?
Ask out of you and me.
Yeah. And so, I see a lot of people get misdiagnosed as well. And unfortunately go through a lot of chaos before somebody just does a better assessment of what's going on. And I don't think all the physicians are bad people, but I think insurance companies dictate oftentimes what gets done. And so, hey, let's not run any more tests than we need. Most of the people are type 2 if they're an adult, so treat them as if, and if they don't get better, then we'll run more, right?
It's the same with thyroid, right? All they look at is TSH. Mm-hmm. Oh, you're good.
Yep. Very same problem across the board, right? We don't do a good job looking. So then we've got type 2, right? And the type 2, kind of explain, like the type 1, what we're going to see: glucose, hemoglobin A1C, and insulin, type 1.5 versus a type 2, at least at the onset.
Yeah. Okay. So, and remember, type 2 is not my specialty, but I can answer basic questions. So in type 1, so first of all, are we assuming your audience knows what a C-peptide is?
You could go ahead and explain it.
Okay.
Do you feel comfortable with that?
Oh yeah, of course. So insulin, the body's brilliant, right? It has insulin in reserve, waiting for the second your blood sugar goes up. And that inactivated insulin, the insulin molecule, is connected to a C-peptide molecule. And that's just the way the C-peptide makes the insulin not active. Mm-hmm. The second the blood sugar goes up, the pancreas activates the insulin. It secretes the proinsulin. It cleaves off the C-peptide. The C-peptide is just now floating around and it recycled, and the insulin is now activated. So, for example, in someone like me who does not produce my own insulin, my C-peptide is 0. My C-peptide is 0. There's no C-peptide going on here for me. So when you are not injecting insulin, we can see indirectly how much insulin you're making by how high or low your C-peptide is. It's just another more thorough way to look at your insulin production. But you can look at insulin production, you can look at C-peptide. If your insulin production is low, your C-peptide is going to be low. There's no way you can have them off. Right? Insulin high, C-peptide. So that's what C-peptide is.
And C-peptide kind of is thought of as a little bit more stable of a marker, but it's more expensive. So you'll see a lot of people just run insulin because it's a cheaper marker.
It's cheaper. Yeah. And insulin can vary dramatically based on what you're eating, from meal to meal, for sure. And that actually, made me think of something that I wanted to say. Personally, when I ask people to get a fasting blood glucose, I tell them to get a meter and have it at their bedside. Mm-hmm. Because if they wake up and then they rush and then they're in traffic and then they're late, their cortisol is going to be through the roof. And although they haven't eaten yet, because now they're getting blood drawn at 7, the fasting is not going to be accurate, right? If we authentically want to look at how well can your body manage your glucose in the absence of food, that means also in the absence of stress, we need you to have the meter by your bedside, open your eyes, and then poke your finger. That's my little 2 cents about that.
And I totally agree with you, and that's why I tell people a fasting glucose by itself is not a very reliable marker by itself, because stress, you typically have a cortisol awakening response. So your cortisol is kicking up in the morning to raise your glucose naturally, right? So if somebody's got a little bit higher glucose in the morning, they're like, oh, it should be right between here. But based on what? You are running around doing stuff. Your insulin's fine. Your hemoglobin A1C is fine. Don't worry about it. You were probably stressed. Was there traffic? Was there this? Do you like getting a blood draw? No. Okay. Well, guess what? Your glucose, your epinephrine's kicking that up. A little stress response there, right? So I totally agree with you. If you want to know what a true fasting glucose is, put a CGM on, stick your finger, and you know what? I even think the person who's stressed out, like I got to stick that thing in my finger, and they're worried about, like some of us, oh, that hurts, right? Not a big deal. But for somebody who's a little shy of that stuff, right? You got to do more than just a glucose at the lab, right? So go ahead, go jump into the rest of that.
Yeah. Okay. You have to remind me what I was answering now.
We were talking about type 2 diabetes, what we might see when we look at the labs, right?
Okay. So type 1, the insulin production of C-peptide is going to be low. Absolutely. Because the beta cells are being attacked by the immune system. That is type 1. In type 2, it can be all over, because initially the insulin production is going to go up, right? If they have insulin resistance, then the body has to make more and more and more and more insulin, and insulin and C-peptide will be up. And then as the disease progresses, then the insulin and the C-peptide could go down. But initially it's high, it's elevated.
Right. And so you, as Dr. Jody was talking about earlier, at some point you can exhaust a tissue. And if you keep pounding away at the pancreas to continue to make lots and lots and lots of insulin, at some point you can exhaust the system. Plus all the inflammatory mechanisms that go along with the high blood sugar can also trigger hypothyroidism, hyperthyroidism, that also affects the pancreatic output. So now we got this thing that we're hearing about called type 3, and I know it's not necessarily your specialty, but can you touch base on what type 3 is?
Sure. I'm assuming you're just talking about Alzheimer's.
I am. Yeah.
So glucose sticks to nervous tissue. We know that diabetic neuropathy is a thing, right? So, and it also can, it damages any nerve, right? Gastroparesis. It's a horrible complication. Gastroparesis is nerve damage to the vagus nerve, and the vagus nerve is in charge of digestion. And my patients that have vagus nerve damage, guess what? They eat their food and they never know when it's going to digest, which is horrible, because then they never know when to dose their insulin, right? What if they dose their insulin expecting this food to raise their blood sugar, but the food doesn't digest for 3 hours because the vagus nerve is so damaged, it just kind of kicks in whenever it wants eventually. So guess what? Brain tissue is nerve tissue. So there's that. And then there's also just blood sugar dysregulation. Well, this is more in type 1, but low blood sugars, constant low blood sugars cause brain damage, as well. That's why you go into a seizure and a coma, and because your brain cells are not getting fed the glucose if you're low, right? But hyperglycemia, for sure, it inflames nerve cells, it damages nerve cells. So brain's included in that.
Yeah. And for the listener, I think probably one of the more common things we think about with blood sugar, especially is in the older population, what we call peripheral neuropathy. And people start to lose their peripheral nerves in their toes and their fingers, and they lose that long before they even realize they're losing it. They have chronic back pain. They shuffle when they walk. Their head's always down. They're probably losing function in their peripheral nerves. They don't even realize they're losing it, but the glucose just damages the nerves. And remember, when you have too much glucose in the system, the glucose can still get into cells even without that insulin to some degree. And as the glucose goes in, sometimes you're bringing fluid in with it, and then you're just destroying the nerves. So it's really a systemic inflammatory process and damage. So that's type 3.
Yeah. And the liver and the muscles need insulin to bring the glucose in. The brain does not. Right. The brain just doesn't have a filter. If you have high blood sugar level, you have too much sugar in your neurons. Yeah. Like there's no neurons don't filter it out.
Yeah. So there's another thing we talk about, and I'm not sure I think you kind of started already to allude to it, but we'll talk about people develop something called reactive hypoglycemia. Can you,
Sure.
you feel comfortable talking about what that is and what those symptoms might look like? Because that's a good indication that you're already, I don't care what your fasted glucose is, I don't care what your insulin is, if you're having that reactive hypoglycemic stuff going on, you already have blood sugar regulation issues going on.
Yeah. Yeah. I see that as just the beta cells a malfunction. You know, if the beta cells are overproducing because, you know, I see this in newly diagnosed type 1s a lot. Anytime they're high, then they have a massive low because the beta cells kick in, and they'll say, every time they have a low, I said, well, how much insulin did you give? And they said, I barely gave any. And so I see that as beta cell dysfunction, beta cell, you know, misregulation. The beta cells kind of can work in fits and spurts.
I would say the other time you can often see it is in people who have gut issues. Right. So and for the listener, when you eat, and Dr. Jody was talking about that before, is like within minutes of the eating, your GI tract releases a hormone called GLP-1, and GLP-1 stimulates the pancreas to release that kind of preformed insulin she was talking about earlier. So within minutes of eating, as glucose is starting to rise, you release about 50% of the insulin your body is going to release from a meal is going to be released in that first like 15 minutes, right? And so that's a big chunk of insulin. But if you have a gut-based issue or you've lost some of that GLP-1 production, your glucose is rising and rising and rising and rising. And now the body's trying to figure out where to push this stuff and where to store it. And it starts on its decline. And now you get the second phase surge of insulin that's being released, but you're already on the decline. Now the insulin spikes and your blood sugar crashes. And within a couple hours of eating, you're like angry, you're irritable, you got to get something to eat, you're lightheaded, and that's what we call that reactive hypoglycemic effect. So it could be that the beta cells aren't making it appropriately. It could also be because of gut-related issues. And so many people have gut-related issues, especially as a result of eating a trashy, sugar-laden diet, right?
Yeah. So their gut, it's a double whammy. It's exactly what both of us just said. It's like the gut is dysregulated, but also you shouldn't be eating that much glucose anyways. It's like it just is such a stress to the beta cells when you eat that much glucose, and then it's going to, you know, spike your blood sugar. It's going to, you know, it's just on the roller coaster.
So we talked about a couple of things. If somebody's looking at trying to figure out, okay, symptom-wise for blood sugar problems, what are some of the key signs and symptoms that somebody might need to consider to say, hey, I got to go get my blood sugar checked?
Well, it can be so subtle that I'm a huge fan of all these, you know, fasting insulin, hemoglobin A1C, these should be on standard blood tests annually for every American, starting at 40. You know, it should absolutely, it's so easy to miss it. And so not only when you start at 40 on your A1C, that you can see the trend, you know. Now, when your blood sugar level is high, it's going to be brain fog, fatigue, depression. I mean, I always like to make the analogy of like your blood is becomes molasses. It's like, like people are like, how do you feel when you're 200? I'm like, oh, I just feel slow. I don't think right. I'm irritable. I want to take a nap. I'm out of breath. Like when I'm exercising, if I'm high, I don't breathe as well. Right. So it just kind of slows you down, makes you kind of like a slug, makes you like a depressed, irritable slug.
Okay. And so if somebody was going to say, all right, I need to look at things, what are the tests that you recommend? Fasting glucose, you talked about hemoglobin A1C, insulin, maybe a C-peptide, depending on who their physician is, right? Is there do you like to look at some of the calculations to also start looking at blood sugar related problems? And I know you're dealing a lot with type 1s, but there's some things that we can calculate to get an idea of insulin resistance, beta cell function, cell sensitivity? Do you use any of those calculations?
I don't, because first of all, I have a virtual practice. I work with type 1s all around the world. So I can't be there. I can't be anybody's actual physician. I'm a type 1 diabetes consultant. So ordering labs and writing prescriptions, I'm not allowed to do. So I'm really an educator for people with type 1. I educate them on how to keep their blood sugars in range. But with all my clients, they've been diagnosed with type 1. They've been diagnosed with type 1. I don't need to do any testing. They're like, I'm type 1. Can you help me regulate my blood sugar? And that's where I start. So I don't start with lab. And speaking of, here's my glucose. So I run a pretty tight ship. I'm 120 right now. And I actually have my high alarm set at 120, which is why this is orange right here. So that's like already like, okay, let's get lower. And so let's see. So if I click on the screen here, you can see I actually forgot my nighttime shot last night. So I hit a little bit high when I went to bed, and then I had to take a couple shots throughout the night. I was above 120. So I have a long acting insulin I do twice a day because I have to have insulin in my body 24 hours a day, regardless if I eat. And then I take my rapid based on what I'm eating during the day. And because I'm 120 and I'd rather be 80, I'm going to do a quick correction dose right now. I'm only going to take like a half a unit. And if you do the shot intramuscular, IM, which everybody says, don't do the shot IM, don't do the shot IM. The only reason why they say don't do it IM is because it works so much faster. And if you don't know what you're doing, you can cause a massive low. But I'm also only giving a tiny, tiny bit. And so I'm just going to IM a half unit. And now in an hour, I'll be back to 80. Now, I'll be back to 80 faster if I got up off my butt and went on a walk.
Right. So do you find for most type 1s that there's the dispensers, the pods that you can put on and dispense it, do you think that's a better option for a lot of people? Or do you feel like, hey, I can fine tune things better with a monitor and a needle?
Super great question. So everybody's shocked when they see that I'm on shots because everybody assumes I'd be on an insulin pump. So I did work for an insulin pump company. I wore a pump. I worked for them for 5 years. And some people can get a lot better control on pumps. Now, up until a couple years ago, my A1C is 5.3. So I obviously don't need to improve my A1C, right? So it is possible to get really good numbers with shots. So when people come to me, it's really about preference. Some people are so against having something on their body all the time, which is kind of where I'm at. I live in Hawaii. I'm in my bikini all the time. I don't want like my CGM and my pump and my tubing hanging all over me, right? Then I wear a bikini and I look like I'm walking a medical equipment machine. So, however, up until just about 2-3 years ago, there was never a pump that had a brain. Everybody assumed that if you wear a pump, you just plug it in and now your blood sugar is perfect. The pump just takes care of it for you. No, the pump does not take care of it for you. It allows you to fine tune your background drip rate, which on shots, I can't fine tune my background drip rate. I do a shot at 8 a.m. and a shot at 8 p.m. And that's just what I have to accept. Your liver gets out different amounts of glucose throughout the day. And so a flat shot at 8 and a flat shot at 8 a.m. doesn't necessarily reflect the flow of glucose coming out of the liver, which adjusts. When you're on a pump, you can say how much insulin you want per hour, per half hour, 24 hours. You can more fine tune it. Now, in my case, the 2 shots a day work fine. If I didn't eat all day long, didn't dose any rapid, and just did my 2 shots a day, I stay like 90 all day, except for my morning cortisol spike, which I manually do a rapid shot to cover. However, pumps do have a brain now. There are 3 on the market. Omnipod is one, and you said pod, which just simply means doesn't have tubing. All the insulin is right here, and you dose it from your phone, as opposed to an insert, a tube, and then a little pager kind of thing that then you have to push the buttons on the pump. They now are integrated with the continuous glucose monitor, 3 of them, the Medtronic, the T-Slim, and the Omnipod. And so they actually, if they see me trending up, they increase the insulin production. If they see me trending down, they decrease the insulin production. So that is a huge help to a lot of people. Now, it's not going to cover me if I eat a massive, huge meal. The pump still isn't going to be able to just be on a total autopilot. It has a tiny bit of autopilot, but not 100%, right? Because not to mention that when you dose insulin, it doesn't peak for like an hour. Right. So if I ate a banana right now, my blood sugar would go up in the next 5 minutes. And if I dosed my insulin subcutaneously at the same time I ate the banana, I'd be 200. And then another hour or two, I'd come back once the insulin slowly started working. right? So you can't just eat what you want and think the pump's going to take care of it, because the pump's delivery of insulin will always greatly lag the spike in blood sugar that happens after meals. Now, I do recommend eating low carb, of course. So, but all food, I mean, I can eat a piece of fish and go up 75 points in blood sugar over the next hour. So it's not just candy and bananas that raise your blood sugar, you know, it's like, yeah.
So let's talk about like some strategies, right? And we'll do this in like, as a general rule for anybody, right? What are some general recommendations dietarily and nutritionally? And then how would you tweak that to more of your base, which is the type 1 diabetic? So there's a lot of diet religions out there. I think one of the biggest problems we have in our industry is we've circled the wagons and shot in at each other. Instead of saying a whole food diet could be healthy, regardless of it, you favor paleo, vegetarian, vegan, or carnivore, or whatever, and say, okay, the bad people out here is this processed food industry that's hyper sugar loaded. What are your general recommendations for people? And then how do you tweak that recommendation for your type 1 diabetics?
Well, it sounds like we're on the same page, Eric. Eat whole food first. Yeah. Eat whole food. Like chia seed pudding for breakfast is awesome, you know, and eggs or nuts or, you know, any smoothie that's all real food ingredients, like real food. Earth grew it. Earth grew it, right? Yeah. Man didn't make it. So eat real food. 80% of the time is your goal. You know, I still have bread and cheese, right? Or those didn't grow on a tree. But 80%. And then the only thing I add in for type 1 is the lower carbs you eat, the easier it is to manage your blood sugar. You know, you can have oatmeal for breakfast with bananas. You can. It's just going to be a lot harder to dose for. And sometimes I have oatmeal and bananas and I get stressed out because I'm like, okay, how much do I need? And what's the timing? And do I have time to walk afterwards to make the insulin work faster? Guess what? When I have chia pudding, I'm just flat. Nothing happens. I put peanut butter in it. I put sugar-free chocolate chips in it. You know, I put unsweetened almond milk in it and chia seeds. And so just eat real food. That's all we need to do. Like if I was in control of COVID, I'd be like, everybody eat real food. Yeah. You'll feel better. Your immune system will be better, and go on walks. I have things that says, how are you taking your meds? Are you taking your meds? MEDS. M is mindset, mental health. E is exercise. D is whole food diet, and S is sleep. Yep. You know, we could have dramatically changed the face of COVID if people were taking their meds.
Yeah. And I think that's great. And those go to the things that I talk about in my book, the Thyroid Debacle. I talk about the fitness factors, right? And I met with a physician today at lunch, and he was looking for the protocols for different stuff, like supplement protocols. I'm like, there's no supplement protocols. He's like, oh, you didn't put it? I'm like, no, because what does everybody do? They go to the end of the book, they look for the supplements they can add to the load they're already taking, and now they're taking 40 supplements a day, right? Instead of 10 or whatever. And they think they're going to fix it with supplements, right? Medicine's bad, but supplements are better. And I always just say that's greenwashing of medicine, right? Exactly. But if we did the simple things, right? Eat a healthier whole food diet. If we did that 80% of the time, I'm in agreement with you. You do not have to be perfect. Matter of fact, trying to be perfect probably creates more stress, which is going to raise your blood sugar and create a problem. So the vast majority of the time, if you eat healthy whole food and then have a few bad behaviors occasionally where you enjoy yourself a little bit, you're probably going to be okay. As long as you're doing the other things. Exercise is good, not doing it appropriately, right? Not that's a whole nother discussion, but sleep, proper breathing and respiration, emotional fitness, all those things are key. So I totally agree with that part of it. And I think there's this misconception, I think sometimes in the type 1 community, that it doesn't really matter what you eat because you can take insulin to manage it. And I think that's a terrible thing to say, because even though insulin's not this bad thing, too much insulin can be problematic. So do you want to talk about that a little bit?
Oh yeah, absolutely. So I talk about this in my TED Talk. That I guess, the endocrinology and the diabetes, type 1 diabetes professionals, and the standard conventional, there's such this crying out of like from parents, I want my kid to be normal. I want my kid to be like everybody else. I don't want them to feel like they're sick. And so they say they can eat anything they want and give insulin. And so I've been on staff at diabetes camps for years and years, and they serve them spaghetti, and they serve them garlic bread, and they serve them oatmeal, and they serve them cereal, and they just put the little carb counts on the table. Okay, there's 50 carbs in the bowl, or there's 100 carbs in the bowl, and they're like, do your math. If your insulin carb ratio is 1 unit to 10 carbs and you're eating 100 carbs, just take 10 units of insulin, right? And I'm like, horrible idea. First of all, we're not promoting whole food. I don't want anybody to be eating 100 grams of carb at any meal, even if it was 100 grams of pineapple. Like, it's too much, right? So they're generally saying they can eat anything they want, which is not the right thing to say to any child or any adult for that matter in today's world. We need to teach proper nutrition. But number two, insulin is really hard to dose properly. That's what I take 3 months. I take patients for 3 months through my 3-month private program to teach them, even when I'm eating low carb, you have to know how much insulin to dose. It's a slug. I already referred to that. If you have, a banana, you're going to have to pre-dose it at least a half an hour because the insulin takes so long to peak. It is such an art. And the more carbs you eat, the more risk you're taking. Right? I say, do you want to gamble with $100 at Vegas and just kind of have fun, maybe $200? Or do you want to gamble with $1 million? If you gamble with $1 million, you can really lose. And so the more carbs you eat per meal, if you eat 100 carbs, there's 2 major risks that can go on. Obviously, number one, you can have a massive high blood sugar because you didn't dose your insulin properly. But when you have that many carbs, you need such a massive dose of insulin that then you give a massive dose of insulin. And what happens if your digestion is slow that day? The peak of blood sugar doesn't happen for 2 hours, but your insulin is smashing you down 1 hour out because it peaks in an hour. Then you have a massive low, right? So I teach what's called the law of small numbers from Dr. Richard Bernstein. He's in New York. He's had diabetes for 70 plus years. He's 84 and still healthy. And he says that when we eat lower carbs, we have less margin for error, right? Lower carbs allow for less risk of highs. Lower carbs allow for smaller doses, thus less risk of lows. And that whole philosophy, eat whatever you want and dose, is wrong because it assumes dosing insulin is easy. But I know where they got it from, because in 1980, when I was diagnosed, they certainly didn't say that. I weighed and measured every bite of food I ate my entire childhood. I had a little scale. I ate out of measuring cups. I weighed my bread. I counted my grapes. I weighed and measured everything. And guess what? I ended up in a 20-year-long eating disorder, right? Eating disorders and type 1 diabetes are very common. So they are trying to just free up the kids and make them feel like they're not sick and make them feel like they can be like everybody else. But the pendulum has gone from super strict when I was young to way too far the other way. So I like to teach families when I'm working with families with little ones. I said, look, this is not a diabetes diet. This is a motivation for the whole family to eat healthier. Let's eat whole food. Let's eat lower carb. Don't make this Johnny can't have it, but Susie can.
Right.
Don't do that.
And I think we have to do a better job of that. Instead of saying, I want my kid to have everything and not feel restricted, I don't think that's the best thing even from a parenting perspective on anything. I think we need to teach appropriate diet, nutrition, behavior, right? Good habits, good lifestyle. And, Johnny might feel a little bit restricted because everybody else gets to, but that doesn't mean it's right. Right.
Absolutely.
I want my kid to drink. I don't want him to feel left out to not be drinking lots of soda every day. Okay. But there's a price to pay for that. Johnny may feel like he's in the in crowd today, and he's going to feel like he's in the in crowd later when he's got chronic health issues and obesity and he's on metformin. Right. And so you'll keep Johnny in the crowd, but at what cost? Right. And
totally. Like, let's use this as an empowerment. Empower your child, because any child today who's going to eat healthy is going to stick out. They're going to stick out. And so empower them to be confident that this is the right thing to do. And, I can't give parenting advice. And so I imagine that's really hard, but hard is not impossible.
It's not impossible. I think the issue becomes we've had 3 kids. They've all kind of made it through, and there's many times where the answer is no, right? No, right? Because it's not healthy. It's not good for you. And yeah, I know everybody else is doing it. I mean, I don't think my kids, gosh, I don't know how old they were before they had their first soda, right? Because it was just a no. And even my, family members were like, what do you mean they're not, no. They don't need to start that. They don't need to have that. Yeah. And then, initially they're like, oh, not so good. But were they worse for not deprived because they didn't get it? I don't think so. I think, matter of fact, I wasn't deprived of those things when I was younger and had more issues probably related to sugar consumption and stuff. So I think we just need to be able to say to our kids, no, we're not going to do it. And maybe the more we do as a society, setting a higher standard, maybe we'll have less health issues and obesity issues and diabetes issues and thyroid issues and everything else. Because if we don't teach the kids how to eat well and live well now, when they're young, we're just building in the health crisis we have. We're just reinforcing that health crisis. The only way this changes, it doesn't change. This crisis that we have going on doesn't change because the insurance industry changes or the medical establishment changes. That's not what's going to change it. It's going to be exactly that. We have to say, I'm going to make a change in my children, in my family, and then it's going to have that ripple effect, right? Because
the thing that I'm always, I ask my parents, I'm like, who's buying that? Mm-hmm. Oftentimes the resistance maybe from the parent is also their own resistance. Like, what's the parent eating? Is the parent eating Oreos at night and having sodas during the day? Because, maybe the parent's saying, oh, I want my kid to eat like everybody else. It's because the parent doesn't want to change their diet. So you got to, we got to take responsibility at all levels.
Yeah. And I, with a lot of my clients, I'll say the same, to tell them, hey, even though I want you to start with this whole food, maybe anti-inflammatory process, I think the easiest way to do this is we get everybody involved, right?
Oh yeah.
Because if one person's eating a certain way in the family, guaranteed everybody's eating it. And it's too hard. We all have willpower at 8 a.m., but by 6 p.m. and you've walked past the bowl of M&Ms like 10 times, guess what? You're digging in, right? I'm stressed out. What the heck? I deserve it, right? But so, hey, I just eat the bowl of ice cream. Well, if you don't have the ice cream, if you don't purchase the ice cream, right, you'll go for something else. So I think we have to do a better job educating ourselves and our kids. And if we want to have less people developing chronic health issues, autoimmune conditions, we the people have to do a better job, and we can make a difference because we can create a ripple that then starts kind of going out and can create a wave of change. But it doesn't, I think many people are saying, well, I'll just wait until the insurance company gets it figured out or healthcare gets it figured out. They'll never figure it out. This is too profitable of a process at this point in time. And that's probably not a nice thing to say, but I think there's no hurry to fix what's really wrong here because it's a massively profitable model.
Yeah, the food industry and the pharmaceutical industry are married.
all big media, big food, big pharma, all those organizations are, they're all businesses, right? And so this is big business. So let's finish up with a couple things. One, you've primarily focus on people with type 1 diabetes, right? And
100%.
So if somebody has type 1 diabetes and they need help, help us understand, help the listeners, if there's somebody who's listening to this who's got type 1 diabetes, explain to them how you work and how you might help them.
Yeah. Well, I've been helping type 1s around the world now for 10 years. So I've helped, hundreds of thousands of people now. And very few of them are properly educated on how to dose their insulin properly. So I have a 3-month program where we look at the background insulin, which is called the basal rate if they're on a pump, or long acting if they're on shots. And I teach them how to check that, if it's even dosed properly. The majority of people that come to me don't even know that they were given the dose, they were given the basal rate, and they don't even know how to adjust it. I've had multiple people. I had one guy who came to me on 50 units of long acting a day, and he's fit and he's healthy and he works out every day. And I'm like, that is way too much insulin. And I'm like, do you go low a lot? He's like, yeah, I snack all day. And I'm like, well, you're only snacking all day because your long acting is so high. So I have him fast. I check out what the number is doing when he's fasting, and no rapid on board, no food. And that's how we can set the long acting. We have to see what the long acting is based in that scenario. Like, so many patients come to me and they show their numbers to their doctor, and the doctor starts tweaking their long acting. And I'm like, were you fasting when you looked at the numbers? He's like, no. I'm like, well, how does he tweak your long acting if you're not fasting? Like, you can't see. It's like, you got to build the foundation. So I take a few calls to really understand how to set and base that foundation. So many people come to me and they're like, that's life-changing for me. Another guy came to me, he's like, oh, I eat snacks every 3 hours, 24 hours a day. And I'm like, you have to wake up and eat? He's like, yeah, I was just told that I have to do that when I have diabetes. I'm like, no, you have to decrease your long-acting insulin. Mm-hmm. The only reason why we have to eat is because our insulin is too much, right? Mm-hmm. I did a 7-day water fast once, and people were like, what? I was like, well, you just reduce your insulin so your sugar level stays flat and it doesn't go too high, right? So that's the first set. And that's like life-changing for people to just understand and get set correctly, that long acting. And then the second set of challenges is really how to dose for meals, because dosing for meals is a lot more complicated than just counting your carbs. Protein can raise you, fat can raise you, carbs raise you at different rates, right? Some things spike you. High glycemic spikes your blood sugar quickly, low glycemic spikes your later. And yet, if you only do one shot, you only have one peak time and then one tail, one bell curve of insulin working. And yet the meals are going to digest at completely different times. And so I go into teaching all that. I teach people how to exercise without going low. That's all about knowing how to do. So it's really about the technical aspects of how to dose your insulin properly. If they're not eating healthy, of course, I have a whole cookbook that I can even share with your audience. And it's an e-cookbook, a PDF with all my favorite low carb recipes. So I do, of course, help them with all of the, eating if that's what they need. I help people reduce their stress. I do ask what supplements they're on. I do give cardiovascular advice because that's our biggest risk. So I do bring in my naturopathic doctor training to the appointment as well for other health related problems. But by the end, I want them to feel very confident in how to avoid high blood sugars, avoid low blood sugars, reduce their A1C, and feel empowered that they actually know how to dose their insulin properly. Most type 1s don't. They're high, they're low, they feel overwhelmed, they don't know why they're going high, they don't know why they're going low, they're exhausted, they feel like their doctors don't help them, and I help them.
So I think it's great that there's somebody like you out there to help them. Where is the system broken? Are they not getting enough education or training? Are they getting it like in a shot, like a drinking out of a fire hose right off the bat, and then there's not enough follow-up or like the nitty-gritty training? So the way it's set up is not good.
So many people, they get a fire hose, maybe if they're a family and their child got diagnosed. Well, meanwhile, the family's still in shock. And they have 3 days of education at the hospital or whatever. If you're an adult, you don't even spend the night anywhere. They just, you have LADA. Oh, here's your insulin. See the diabetes educator in 2 weeks. Take some insulin between now and then. They don't know how to dose at all. And then the nuances that I bring in, the fact that you can do an IM shot to make your insulin work faster versus a subcutaneous shot. Nobody's heard that before. The fact that you can do your shot and then go run around, that makes your insulin work faster. That makes your highs come down faster. I had one family tell me once that their child was handed a graph that said, if you're 250 before the meal, take your insulin and wait an hour before you eat. If you're 200 before the meal, take your insulin and wait 30 minutes before you eat. And I was like, no, take your insulin and go run. Actually, so the nuances that I have 12 weeks of a curriculum. This is what we learn on day 1. This is what we learn on day 2. Every day I have people go, I can't believe I've had diabetes for X number of decades. I've never heard this before. I hear that all the time. Not only IM versus sub-Q, but some people only are doing their shots in their belly. And then their belly becomes covered in scar tissue. And then when you have scar tissue, you have absorption problems. So you do your shot one day in a bunch of scar tissue, and you're like, why does my insulin not work? Well, it can't absorb if it's in a bunch of fibrous tissue, right? And then the next day they do their shot and it's not in scar tissue. And then they have a massive low, right? Well, then I'm like, no, you can do your shot anywhere you have a little pinch. I mean, just for fun, I'm an experimenter. I actually pinched up some of my forearm skin once and put my shot in there. And guess what? It worked. Right? If you get insulin under your skin, now I don't recommend anybody try that without working with me because there's a lot of nuances of where you should do your shot. But if you're only doing your shot in your belly, we got to spread that out because we got to reduce your risk of scar tissue. So I talk about cortisol spike in the morning. I talk about growth hormone spike once you go to bed. I talk about delayed onset hypoglycemia, which nobody's ever heard of. So there's a lot of things that I empower type 1s to be able to be like, oh my God, I can't believe I get this now. And you're right. Yes, there is a lack of education. The doctors don't know to what degree. I know most often, some of them do, but not very many. And the time, they have to wait for 3 weeks to see this person and wait for 4 weeks to see that person. You work with me for 3 months. I talk to you every week. You can email me anytime. I have training courses that you can watch 100 times. It's a very thorough education that most type 1s have never received.
And so it is. The nice thing about it too is you're talking about it from real experience, right? Versus book experience, which is different, right? And so, hey, I learned this in a book and this is the way to do it. This is what the guidelines say, but that's when you live it, it's a different story, right?
100%. Yeah. There's a word called brittle diabetes. Like patients will come to me like, oh, I'm brittle. And I'm like, no, brittle diabetes means their blood sugar levels go up and down for no reason. And I think the doctors made up that term when they're like, well, I don't know why your numbers go up and down. You must be brittle. No, brittle is just a lack of education. None of my patients are ever brittle. Like there's so many nuances to what I have an 8-page handout for all the different reasons why blood sugar goes high and low. And so anybody that's brittle, I can help you realize you're not brittle and educate you.
Yeah, that's a terrible diagnosis, right? Brittle.
Yeah, it just sounds like, oh, and people feel like they're victims. Like, well, and they'll come to me and they're like, well, I don't know why I should work with you because I'm brittle. I'm like, well, no, you're not brittle. I can help you. I'm sorry you've been doing that. Because they've been like, well, I've just accepted high blood sugars for decades because my doctor told me I was brittle.
Yeah.
Yeah, it's awful.
All right, so let's do this. We're going to wrap this up because I want to be respectful of your time. We did about an hour and 20 minutes. So if somebody wants to learn more about you, wants to hear more about what you do, or wants to work with you, where can they go? Where can they find you and your information?
Well, the easiest thing to remember is just Google the words Dr. Jody and diabetes. Those 3 words, Dr. Jody diabetes. And my website will come up, my TEDx talk will come up, my YouTube channel will come up, all that. But my website is Dr. Jody ND, Dr. Jody Y, N as in naturopathic, D as in doctor. You'll see my free videos there. You'll see my online courses there. And you'll see a link to apply to have a free intro call with me. So if you want to work with my 3-month program, I have a monthly membership program. So everything's on my website. My TEDx talks on my website, my courses. But yeah, if you want to work with me, sign up for the free intro call and then we'll chat.
Awesome. Well, Jody, I appreciate you coming on the Thyroid Answers podcast. I think we covered quite a bit of material today. It was a great conversation, and maybe we'll get you back on the podcast sometime in the future. So have a great time in Hawaii. Enjoy the beautiful weather. You still got the better part of an afternoon to enjoy, and have a great Thanksgiving, okay?
Awesome. Thanks, Eric. And I learned a lot from you today as well. So thank you.
You're welcome.